All right, good morning, everyone. Welcome back. Good to see you, and thanks for being here this year. Those who are here, those who are on Zoom, thanks for paying attention and joining us. This is our last grand rounds of the year, so yay summer. See you in a few months. This morning we have Dr. Abraham, who is Associate Professor of Medicine in the Department of Medicine, and he is one of our faculty in the Division of General Internal Medicine. Dr. Abraham went to Cornell, and then he went to med school at Temple and did his residency in internal medicine here, and he's been on our faculty since. And so coming up on, is it 20 years, Dr. Abraham? Is that possible? Yes. So pretty impressive. Been on our faculty for nearly 20 years, and over that time has maintained a busy primary care practice. He's also a generalist. He sees patients who are hospitalized at University Hospital. He's an accomplished teacher. He is an avid skier and mountain biker and tennis player, and I'm sorry to say an outstanding ping pong player as well. I've never beaten him, but hopefully someday that will change. Dr. Abraham, more than that, is an excellent colleague and teacher and physician, which is why he was invited to be here with us, to speak with us about this very important and challenging common topic that we as general internists manage all the time, which is COPD. So, Dr. Abraham, thanks for being here. Looking forward to your talk.
Well, good morning, everyone, and thanks for coming this morning. It's been a while since I've seen some of you in person, so it's nice to see you all here today, and it's always an honor to be able to talk in front of this group of smart, distinguished peers and colleagues. And I always learn quite a bit putting together these lectures as a generalist, and I look forward to hopefully sharing some of that with you today. As an aside, one of the things I didn't tell Brandon about is I'm a bit of a political junkie, and I think ironically this is the third time in a row I've presented on an election day. At least for those of us who live in Denver, today's an election day. But fortunately, I think, at least for me, the stakes of this election don't feel quite as great as the stakes of the other elections that I've presented on. So I just spent the weekend feeling nervous about putting together this talk and didn't feel overwhelmed about national elections, which was a nice change of pace. But we're not here to talk about politics today. We're here to talk about management of COPD. And this is a really broad talk. It's sort of a 30,000-foot overview. I had to eliminate some things. So we're not going to be talking about inpatient management of acute exacerbations. This is going to be solely focused on outpatient diagnosis, management, and assessment of COPD. So without further ado, here are my learning objectives for you for this talk. I'm hoping by the end of this session, you can identify spirometry pattern and ratios for the diagnosis of COPD. We're going to do a review of spirometry, everybody's favorite. I'm going to talk about the 2023 GOLD staging system for COPD, which is updated from last year. Fortunately, it's actually been made a bit simpler, but we'll talk about that and how it influences our treatment options. I'm going to show you two validated questionnaires that I think will easily fit into your clinical practice that I didn't know about until I was creating a version of this talk for residents a couple years back. But I think these can easily be implemented into a busy primary care practice in order to help us sort of assess our patients' symptoms. We'll review patients, how to rapidly identify patients who might be prepared to make a quit attempt. Discuss relative advantages and disadvantages of both pharmacologic therapy and non-pharmacologic therapy for COPD. Okay, I know that I have a tendency sometimes to drift off during these lectures and not give full attention for the whole hour. So I wanted to put these references up front because if you find yourself doing that, if you drift off for 10 or 15 minutes, almost everything from this talk can be found either in the GOLD 2023 guidelines or in some of the resources I've put here. I'd highly encourage you guys to download the COPD Pocket Consultant Guide. It's a free app that's available on your phone, and it has great resources, including videos, the two questionnaires that I'm talking about, information about the GOLD guidelines. The National Jewish website there, you can get that by a National Jewish Inhaler video search on Google. but that has references for your patients on how to use all the different forms of inhalers that are out there today. And then the Alpha-1 Antitrypsin organization is a way to get your patients free and confidential testing for alpha-1 trypsin, which we'll talk about. I had initially started this talk with a definition of COPD, but as I was practicing this weekend, when I was reading that definition, my eyes were glazing over. And at 8 in the morning, I figured, why do that to you all? So I wanted to start with something clinically relevant, and that is when to think about COPD. I think this is probably a review for almost everyone, but think about COPD in your patients who have a significant smoking history and progressive cough, dyspnea, or sputum production. And if you're thinking about that in your patient, you want to get spirometry. Spirometry is how you formally diagnose COPD. So it's the main tool that we use, and what you're looking for is a post-bronchodilator ratio, FEV1 to FVC, of less than 70%. So if you have the right patient, patient with a history that's suggestive of COPD, and you get that spirometry, and the post-spirometry ratio is less than 70%, you have confirmed the diagnosis. Spirometry is necessary for a formal diagnosis of COPD, but it's not sufficient. So if you have the wrong clinical context, the spirometry by itself doesn't diagnose COPD. Okay, so this is a patient similar to one in my practice. A 69-year-old man comes in with slowly progressive shortness of breath over the past year, along with some cough. He has a 40-pack year smoking history, never been hospitalized for breathing issues, and he's got a normal pulse oximetry when you examine him, distant breath sounds, no wheezes, and no rhonchi. So question number one, there's going to be several questions to highlight key points here. This is his spirometry, and we'll go through this. I think these spirometries are challenging to sort of look at and understand quickly what's going on. So we'll point out the key features here when we talk about the answer to this question. But just looking at this now, I'd like you to try to answer this question. So based on this history and spirometry this patient has, is it A, COPD with mild obstruction, B, COPD with moderate obstruction, C, asthma, or D, restrictive lung disease? And I'll give you about 10 seconds to think about your answer. We're going to go through some things and then come back to this slide. Okay, the next half dozen slides are the spirometry section of the talk, so I hope you guys are well caffeinated. I learned spirometry, dating myself here, a quarter century ago in medical school, which is amazing to think about that it was that long ago. And I learned it really well from my pathophys test. And then, you know, periodically, maybe 6 times a year, I would get spirometries back in clinic. And I always kind of had to review what was going on. So I thought it was worth going through basic spirometry. This will probably be a review for almost everyone, but we'll talk about the highlights for COPD. So when we're thinking about obstructive lung disease and COPD, the main things we want to look at are the FEV1 and the FVC. And if you'll recall, the FEV1 is the amount of air that a patient can blow out in 1 second. The FVC is the total amount of air that they can exhale in one breath. And then we're really interested in the ratio for obstructive disease. So we're looking at the amount of air that they can blow out in 1 second over the total amount of air that they can exhale. You don't have to get 100% to pass this test. So a B- is good enough for spirometry. So anything above 80% of predicted is normal for our spirometry values. The FEV1 to FVC ratio varies. It actually is supposed to go down with age because lungs get a bit stiffer. But anything above 70 to 80% is normal for your ratio, and anything below 70% is abnormal. So this is a volume over time curve, and I'm going to show you the difference for a normal patient versus COPD. In our normal patient, they're able to blow out most of their air in that first second, and then their volume sort of plateaus thereafter. Our patient with obstructive disease has stiffer lungs, less compliant lungs, and more air trapping. So during that first second, they can't get out quite as much air, and the total amount of air that they blow out is also lower. And that's reflected in their ratios, which you can see here. This patient has a ratio of 56%. So that would be consistent with obstructive disease. So this is sort of intuitive to me. What we see on our spirometry, though, is not the volume over time graph. It's actually a flow over volume graph, which is a little less intuitive because it doesn't have time on the axes. So this is the expiratory portion, or the top portion of a flow volume loop. Ignore the green, that's restrictive disease, which we're not talking about today. The concepts are sort of the same. So the initial flow for a normal patient is much greater. The initial flow for someone with obstructive disease is much lower. And then that red graph, you can see that the patient sort of has a characteristic scallop or convexity at the end of expiration. And so that red graph is really classic for a patient with obstructive disease. Once we've diagnosed obstructive disease with those ratios less than 70% after bronchodilator therapy, the way that the GOLD system categorizes the degree of obstruction is by looking at the FEV1 after bronchodilation. So they grade it anywhere from mild to very severe. So your mild patient still has a relatively preserved FEV1 of greater than 80%. And then your very severe patient at the bottom there is less than 30%. And moderate and severe are somewhat in between. But this is how we assess the degree of obstruction, which is part of sort of the staging system for COPD. So going back to that initial question, I'm going to take you through this spirometry if I have a pointer. Brendan, do you know if there's a pointer available? Oh, here we go. Okay, there's several mouses up here. I found the right one. So I think these are very hard to look at. I think this is really an example of poor design, but I won't go through a diatribe on my my concerns about the spirometry values as they're reported. I'm just going to highlight the important things. So if we're looking for obstructive disease, this is our pre-bronchodilator values. And our ratio here of FEV1 to FVC is 64%. The FEV1 is 71%. Then the patient gets a bronchodilator, and you can see with this patient, their values really don't change. So their FEV1 to FVC is 63%, and their FEV1 is 71%. If we look at the flow volume loop here during expiration, they also have this characteristic scalloped curve. So this is classic sort of COPD finding in patient number 1. And based on the post-bronchodilator FEV1 of 71%, they have moderate obstruction. So the correct answer to that first question was COPD with moderate obstruction. All right, so now we've diagnosed a patient with COPD. What do we need to assess other than their spirometry? And so I'm gonna bring this up with a question and then we'll talk through it. So question 2 is, which of the following is not a component of the 2023 GOLD Guidelines COPD assessment? Is it A, FEV1, B, total eosinophils in peripheral blood, C, the number of exacerbations the patient has had in the past year, or D, the degree of dyspnea as measured by a validated questionnaire? So I'll give you again about 10 seconds to think about your answer. We'll go through things and come back to this slide. Okay. So according to the 2023 GOLD guidelines, there are 4 factors we want to assess in our patients who have obstructive disease. And the first we've already talked about, that's the presence and severity of spirometry abnormalities. But that's not the only thing we want to think about. We also want to think about the patient's symptoms. So do they have cough, dyspnea, sputum production, fatigue? And that's where our validated questionnaires that I'll show you come into play. The third thing we want to think about are history of exacerbations, and I'll talk about how we define those and why they're important. And then the final thing that we want to talk about, which are, I think, emphasized more over the past decade of GOLD guidelines, are their comorbidities. I'm not going to talk a whole lot about comorbidities because as general internists, I think we think about those a lot anyway. But suffice to say that our pulmonary colleagues are catching up and realizing that these are also very important in patient outcomes. Just a few final thoughts on spirometry. So spirometry is necessary for diagnosis. The degree of obstruction correlates with exacerbations, and it also has prognostic information for mortality. Although for any individual patient, the degree of obstruction is not a great predictor of mortality. There's a huge variance, and so it's much better across a population of patients as opposed to any one individual. And then finally, when we talk about sort of second, third, and fourth line treatments, most of those have been studied in patients with severe or very severe obstruction. So you can use that when you're considering sort of second, third, and fourth line treatments. Couple limitations of spirometry. It is sensitive but not specific for COPD diagnosis, so it's a better rule out than rule in test. Has a weak correlation with symptoms and health status, so you can have someone with severe COPD that's doing very well in the community and another patient who's miserable. Degree of airway reversibility is not static and can change over time, and in fact the GOLD guidelines recommend if you have a high suspicion and your FEV1 to FVC ratio is not confirming the diagnosis of COPD, but it's less than 0.8, you might want to repeat that test. And then this is a big change compared to when I got out of residency 20 years ago. We used to look hard at the reversibility of the spirometry, and we felt that that was a good predictor of patients' response to corticosteroids. That's no longer the case. So the degree of reversibility does not predict response to corticosteroids in patients with COPD. We'll talk about another factor that's now recommended to check, but checking spirometry reversibility in patients who continue to have a fixed obstruction is not going to predict a response to corticosteroids. Okay, so we need to look at other factors, and these are the two validated questionnaires that I was talking about for symptom assessment. The first one is actually was developed in the 60s. It's called the MMRC, and it's basically just a one-item scale that assesses dyspnea. So very easy to implement in clinical practice. The second is called the CAT, or the COPD assessment tool or test. It's an 8-item scale. So if you combine the two, you're basically asking your patient 9 questions. So very similar to what we do with the PHQ-9. And I think this, thinking about this, the way we think about the PHQ-9 is a good way to look at it in terms of assessment and ongoing management of COPD patients. These scores are widely available, so you can find them on MD Calc. They're available on that COPD assessment app that I told you about, so you can get them in lots of different places. This is the first one. It's just the one-item MMRC. It asks the patient how dyspneic they are. So 0 is they only get breathless with strenuous exercise. 4 is they are so breathless they don't leave the house or they get short of breath when dressing. Anything above a 2 on this is what we're looking for when we're thinking about therapy, and I'll explain that more later. I have not seen them on Epic. They may be, but I've never looked for them on Epic. I've never seen them in pulmonary notes either, interestingly. This is the CAT assessment, which is that 8-item questionnaire. This is scored between 0 to 5. And it asks not just about dyspnea, but also about cough, energy level, chest tightness, and all the other symptoms we're thinking about with patients who have COPD. Anything above a 10 on this is considered sort of a positive test or a test that might influence our treatment. Okay, so the importance of these two scales. So first of all, the MMRC, you can use that as part of a tool to predict future mortality risk. As I mentioned, scores above 10 and 2, according to the GOLD guidelines, kind of categorize patients into a different category, which we'll talk about more. And then I think it's a good idea to think about using these the way we use our PHQ-9. These are the symptoms we want to impact. So when we treat a patient, it would be nice to know if we're impacting those symptoms in a little bit more objective fashion than just asking them if they feel better. And so you can use these at follow-up. And if you're not making an impact, you need to think about, is your patient adherent to therapy? Are they using their inhaler correctly? Do I have the right diagnosis? Do I need to change something? All right, moving on to the third thing that GOLD recommends we assess, that's exacerbations. So exacerbations are basically defined as an increase in symptoms, specifically dyspnea, cough, and sputum production over a fairly short period, so over less than 14 days. And these would require an increase in the patient's therapy. So that could be just an increase in their short-acting beta agonist, or it could be antibiotics or steroids, or it could be a hospital stay. But these are sort of key, almost sentinel events for patients with COPD. They've been shown to worsen overall health status. In fact, at 8 weeks, about 20% of patients have not returned to baseline after an exacerbation. They're associated with disease progression, and the best predictor of whether your patient will be re-hospitalized is whether or not they've been hospitalized initially. So these are kind of key events that we want to try to avoid. And then finally, I mentioned this, I'm not going to spend a lot of time on it, but comorbid conditions also influence the natural history and morbidity and mortality of COPD. Obviously, a lot of these patients are older patients who have smoked for a long time, so it's not surprising that they have lots of comorbidities often. And thinking about making sure those other comorbidities are well managed will influence our patient's health status. Again, I think that's what we do as general internists, so I think we're ahead of the curve here. But our pulmonary colleagues have put these into the GOLD guidelines and really emphasized them recently. I did put alpha-1 antitrypsin in here as well, just because I didn't know where else to put it. But the GOLD and the WHO guidelines all recommend one-time assessment of alpha-1 antitrypsin in all COPD patients. I honestly can't say that I've done that on a regular basis, but that is guideline recommended according to both the WHO and GOLD. And I think there's level B evidence that replacement of this therapy can be helpful. From what I'm told, it's really expensive. These tests are really expensive, but if patients are referred to the alpha-1 trypsin organization, there actually is one that exists, through that alpha-1 website, they can get free and confidential testing. So that's a good reference to have for your patients. Okay, this I think is an important slide that summarizes how we should assess patients for COPD and will influence how we manage them. So I'm going to go through this from left to right. So we have a patient that we're concerned may have COPD. We get spirometry. We confirm their diagnosis of COPD because their post-bronchodilator ratio is less than 70%. The next step is to assess the degree of severity of obstruction, and that's also just from your spirometry. So that's your post-bronchodilator FEV1. Once we've done that, then this bottom box here is really based on symptoms, and that's where your validated questionnaires come in. So I'm going to take you through this. This was a 2x2 box last year. They've changed it to a 2x1 box. So now we just use 2x2 boxes, I guess, for sensitivity and specificity. We're left with a 2x1 box for COPD. But it's fairly easy. So the top half of this box is just exacerbations. So if your patient has had one exacerbation that's led to a hospital stay in the past year, they fall into the E category here. Or if they've had 2 or more exacerbations that haven't required hospitalization, they would fall into the E category. If they haven't had exacerbations in the past 12 months, then they're either going to fall into category A or B. If they really don't have much in the way of symptoms, they're category A. If they have either an MMRC of 2 or more, or a CAT score of 10 or more, they'll fall into category B. Now, most of our patients, when they're coming to our attention, it's because they're having symptoms. So at least initially, most of your patients are going to fall into category B or A or E. And then sort of the goal I would look at is trying to get them down into category A. But for the purposes of initial treatment, most patients are going to have symptoms or are going to be hospitalized. That's how you're going to know that they have COPD. And when we talk about treatment, you'll see that the box that they fall into influences what the recommended treatment is. All right, the rest of the talk really is going to focus on treatment, and I'm going to kick this off with a question about treatment. So which of the following treatments have been shown in clinical trials to reduce mortality in patients with COPD? Is it A, oxygen therapy for patients with only exertional hypoxia? B, inhaled corticosteroid therapy? C, smoking cessation among patients with mild COPD? D, pulmonary rehab after hospitalization for COPD? E, both answers A and C, or F, both answers C or D. So this is a tough one. I'll give you about 10 seconds. The answer for this is going to be on the next slide, so make sure you put your nickel down and then we'll talk about it. Okay, so the correct answer to this one is both C and D. So oxygen therapy has been shown to improve survival if patients have resting hypoxemia, but not if they have exertional hypoxemia only. Inhaled corticosteroid therapy has not been shown to influence mortality. It has been shown to reduce exacerbations in a select subset of patients, and we'll talk more about that. Smoking cessation among patients with mild COPD has definitely been shown to improve survival. And then pulmonary rehab has lots of benefits, but it's been shown to improve survival among hospitalized patients. So outpatient treatment of COPD, I think you can break this down into two big categories. So there is non-pharmacologic treatments and there are pharmacologic treatments. And we'll talk about both of those. And then there's sort of first-line therapies and then advanced therapies for both of those options. Let's start with non-pharmacologic management. And I'd be remiss, I think, if I didn't start with tobacco cessation. So this is the thing that can have the greatest impact on your patient's future morbidity and mortality. It's hard to do. I think we all know that. But in some studies, with adequate resources and time, sustained quit rates as high as 25% have been demonstrated. I've been super impressed with, I'm going to butcher this name because I always use the trade name, but I'm not going to do that at GIM Grand Rounds. Varenicline, I've been shocked at how well patients have done. Folks that have smoked 2 packs a day that I never thought would quit. I've had some of them quit entirely. Some of them get down to like 5 cigarettes a day, which from a harm reduction standpoint, I think is great. The problem is, I think, getting long-term insurance coverage. And I've been less impressed for sustained remission for patients who stop this medication. It seems like a lot of them sort of, relapse and smoke again once they stop the varenicline. Bupropion I've been less impressed with, but it is FDA approved for smoking cessation. The 1-800-QUIT-NOW, I learned this week when I was putting this together, is actually a national number. I thought it was just for Colorado, but it's actually national. And then we're fortunate to have a tobacco cessation counselor that I think does an excellent job with patients that I've referred. So think about using them if you have patients that are looking to quit or ready to quit. Just one more slide on tobacco cessation because it is really important. Remember the 5 A's as sort of a framework for behavioral, any sort of behavioral treatment. And then the thing that I'd like you to remember the most is the assessment question. So that's, are you willing to make a quit attempt over the next 30 days? And if a patient says yes, and they're really prepared to make a quit attempt, my suggestion is to focus as much of that visit as possible on their smoking in order to give them the resources that they can get to best increase their chance of quitting, just because it is so important. Pulmonary rehab is the second thing that I wanted to focus on because I think we underutilize this as well. Pulmonary rehab really shows good data for quality of life and shortness of breath among all stages of COPD, although it has the most demonstrated benefit for patients with moderate to severe obstruction. The other thing I wanted to point out is that it doesn't have to be months or years of pulmonary rehab. So really just 6 to 8 weeks has been demonstrated to have benefit for patients. So if your patient has anything more than just mild symptoms, I would consider referring them to pulmonary rehab. Again, we're fortunate to have a pulmonary rehab program at the university. The big issue that I've had is getting patients to buy in to pulmonary rehab. But if they do, I think it's a great thing to offer them. And then oxygen therapy, again, shown to increase survival in patients with resting hypoxemia, not shown to have a survival benefit in patients who only have exertional hypoxemia. The one other caveat I wanted to point out here is that pulse ox can be abnormally elevated or falsely elevated in long-term smokers because of carboxyhemoglobin. So if you have a patient that you're really suspicious might be hypoxic and you're getting normal pulse oxes in the office, the best way to test is to actually send that patient for an ABG. I don't know how easy that is to get at Anschutz. I know we really can't get them over at Lowry. So I think we'd have to send the patient to the hospital to get an ABG. I've never actually done that. I don't know if anyone at Lowry has. Okay, we're gonna move into pharmacologic management, and I'm gonna start this off with a question about inhaled corticosteroids. So question 4 is regarding the use of ICS, inhaled corticosteroids, in patients with COPD. Which of the following is a true statement? Is it A, ICS should be offered as part of first-line therapy to all patients who have persistent symptoms? Is it B, patients with serum eosinophils less than 300 on peripheral blood smear are more likely to benefit than patients with higher eosinophil counts? Is it C, using ICS is associated with increased risk of pneumonia? Or is it D, monotherapy with inhaled corticosteroids is indicated in patients who have persistent obstruction, but a good degree of reversibility on their pulmonary function tests? So I'll give you about 10 seconds. We'll go through pharmacotherapy and then come back to the answer. Okay. Pharmacotherapy for COPD is relatively simple. There's 2 big categories of medications. There are inhaled bronchodilators or bronchodilators, and there are anti-inflammatory medications. And then the inhaled bronchodilators really come in 2 flavors. There are beta agonists, which relax smooth muscle and allow bronchodilation. And then there are muscarinic antagonists, which block sort of bronchoconstriction from acetylcholine. So those are our 2 classes of medications. And I'll point out in future slides that really our long-acting muscarinic antagonists and our long-acting beta agonists, those are the mainstay of therapy for COPD patients. We'll talk about why that is. This is very different from asthma. So in patients who have asthma, inhaled corticosteroids are really our mainstay of therapy. That is not the case in patients who have persistent obstructive disease. So inhaled corticosteroids probably have a role for a subset of patients, but they really shouldn't be first-line therapies. And then we'll talk a little bit more about oral therapies that I look at as more second or third line. One other non-pharmacologic thing that we should think about, it involves pharmacotherapy, but it's not a pharmacologic management, and that is inhaler technique. So there are now over 30 medications that are inhaled medications for COPD. I think there are at least 5, if not a half dozen, different delivery systems for these medications. And there are studies showing that about 70% of our patients are doing something wrong with their inhaler, so may not be getting the full benefit of their inhaled medication. So I personally don't know how to use all 6 different inhalers for COPD or asthma. But I think this is an area that's ripe for a team-based approach. So hopefully the pharmacist knows how to use them. If not, there are care notes available on Epic for each different type of inhaler. There are videos available both on that COPD Pocket Consultant Guide that I pointed out, which patients can also download. There's a whole patient section for that. There are also videos from National Jewish that you can get to. So we'll talk a little bit more about this, but this is, I think, really important if a patient isn't responding to treatment to make sure they're using their inhalers correctly. Okay, moving on to the specific medications. Short-acting beta agonists are pretty simple. All patients should have this for either intermittent symptoms or as a rescue inhaler, pretty similar to what we do for asthma. So prescribe this to your patients, but it really shouldn't be the mainstay of their therapy. They should have one available, but they shouldn't only be using this, unless they're very intermittently symptomatic. Long-acting beta agonists, these can be used as monotherapy for COPD, although they're probably not the best initial choice. So these are once or twice daily preparations that relax smooth muscle. Side effects are increased tremor and tachycardia. Obviously, you guys probably know these medications are fairly expensive compared to some of the meds we prescribe, like statins and blood pressure meds. So that, I think, is the biggest side effect of these meds, is that they can cost a lot. Long-acting muscarinic agonists, as I mentioned, they block acetylcholine's effect on muscarinic receptors and lead to bronchodilation from that impact. Again, I think cost is the biggest downside of these meds. They can cause some dry mouth and some urinary retention, but I haven't found that to be a huge problem for patients. There are clinical trials that show a greater decrease in exacerbations for these as compared to the LABAs. So if you are going to prescribe one medication and all things are equal, I think this might be the one to start with. But probably combined therapy is best, as we'll talk about on the next slide. All right, so a combination of LAMA and LABAs is probably our best initial option. You can do this either separately, or there are lots of inhalers that come with both medications. Why is it our best option? Well, there's level A evidence that it significantly reduces symptoms and increases FEV1 compared to monotherapy. There's level B evidence that it reduces exacerbations compared to monotherapy. So if all else is equal, I think it's probably worth prescribing these as initial therapy to any patient who's persistently symptomatic with COPD. I did want to bring up cost. I accessed this over the weekend because I was curious to know, is combined therapy a lot more expensive than monotherapy? So I put the beta agonists in dark green there and the muscarinic antagonists in lighter green. So you can see that if a patient doesn't have insurance and they're just using coupons, the long-acting beta agonist was the least expensive, at least right now, on GoodRx. So then I ran this by our clinical pharmacist to see if patients with insurance would also, face a similar difference in copay. And he assured me that at least for governmental insurance, which he's more familiar with, they're all the same. There's no difference in copay for patients who have governmental insurance. He wasn't sure, every private insurance is different, but he did not think that there would be a big difference with dual therapy compared to monotherapy. So I don't think cost is really a reason to avoid combination therapy in and of itself. Okay, we'll see how this goes. This is going to be a little bit different. There's a method to my madness. So this is going to be a way to ingrain that LAMA-LABA therapy is first-line therapy by the recording artist Ludacris is going to read a bedtime story, Llama Llama. We'll see how this goes. I'm presenting in Estes Park next month. So depending on how awkward this is, this may or may not fit into the presentation next month. All right. So you may not remember anything else from this talk, but you'll probably remember the Ludacris interlude. So when he says Lama Lama, think Lama Laba as your first line therapy. I'll have to talk with Dr. Lebduska, who invited me to Estes Park, to see if she wants me to keep that in the talk for next month. That is definitely not going to happen. You have to take a lot of propranolol to get me to wrap. All right, inhaled corticosteroids. These are not first-line agents by themselves for COPD, so very different from asthma. Inhaled corticosteroids are associated with an increased risk of pneumonia. There's at least one study that shows a higher mortality when you compare it to placebo or combined LABA-ICS therapy. The role for ICS is really in patients who are already on dual therapy, particularly if they've had lots of exacerbations and they have high eosinophils. And we'll talk about why that is in a moment. In addition to pneumonia, there's also an increased risk of candidiasis, hoarse voice, etc. So instead of using reversibility on PFTs as a marker for response to corticosteroids, the guidelines actually now recommend that we look at blood eosinophils, which was totally new to me a couple years ago when I was putting this together. So the data support, the benefit is higher if the patient's peripheral eosinophil count is higher. So if it's above 300, that's really where patients seem to benefit the most. If it's less than 100, they seem to have no benefit. So the GOLD committee has put together this nice chart about factors to consider when you're thinking about ICS therapy. So the green there is things to use ICS for. So if a patient has lots of exacerbations, blood eosinophil count is high, they're already on LAMA-LABA therapy, that's where you can think about ICS therapy. If they've had lots of pneumonias, their blood eosinophil count is low, you probably want to avoid ICS therapy or take them off it if they've already been using it. All right, so I said that 2x1 box would influence our treatment, and I'm coming back to it now. So this is what GOLD recommends for 2023. So you can see most patients, remember ludicrous, are in the LABA-LAMA category. So as long as they have anything more than sort of mild symptoms, if they have exacerbations up here in group E, or they have significant symptoms, then your dual therapy is first-line therapy. If they're still having exacerbations despite being on this therapy and their blood eosinophil count is high, that's where you want to consider adding ICS and getting them on triple therapy. So question 4, going back to that initial question, the only thing true here was that use of ICS is associated with an increased risk of pneumonia. ICS is not first-line therapy for COPD. Patients with lower eosinophils benefit less than patients with higher eosinophils. And reversibility of obstruction on PFTs is no longer considered the thing to use when you're thinking about ICS. Couple of oral agents that are available as second or third line therapy. So roflumilast is an oral agent that is a bronchodilator. This has basically been studied in patients who have severe or very severe obstruction. So that's where your PFTs can help you determine whether or not this might be appropriate therapy. There is a significant side effect profile of this medication. So it can cause lots of GI side effects. It can also cause headache. I thought it was expensive, but I looked this one up on GoodRx as well. It's no longer expensive. So $21 for a 30-day supply, which I thought, that's much less than most of the inhaled inhaled LAMA-LABA agents. And then antibiotics are another choice for patient with frequent exacerbations. So I think Rick Albert was involved in the initial studies on azithromycin back when I was a resident, so 20 plus years ago. But the data suggests that this can reduce hospital exacerbations for patients who have been frequently hospitalized. If you're using azithromycin, it's just 3 times a week, it's not daily, but you do have to think about QTC interval, and ototoxicity is actually a side effect of long-term azithromycin use. So it definitely has some potential downsides, but patients that are being frequently admitted to the hospital with COPD Unfortunately, their prognosis probably isn't great, so I would worry less about the long-term side effects and more about keeping them out of the hospital. So just a summary to recap pharmacotherapy recommendations, because I think this is one of the main things that we do as general internists. Start with LAMA LABAs, remember the ludicrous interlude. Review those standardized questionnaires. So use those to monitor your response to therapy. And if patients aren't doing well, think about why. Review exacerbations over the past 12 months. Make sure they're using their inhalers appropriately if they're not doing well. So I won't say before you pull out your prescription pen, because we don't really use pens anymore, but before you click on Epic for another prescription, make sure that your patients are appropriately using their inhalers and getting the most benefit out of the meds that they're already on. If they are using their inhalers appropriately and they're on appropriate therapy, consider adding steroids if their blood eosinophil count is above 100. And then reserve azithromycin and roflumilast for patients who have severe disease, multiple exacerbations, if they're on triple therapy already, or if their eosinophil count is pretty low to begin with. Okay, we'll briefly go through advanced non-pharmacologic therapies. Those first two there, I think our pulmonary colleagues are going to help us with. The last one, obviously palliative care and hospice referral, we should be pretty comfortable with as general internists. So sort of home, non-invasive positive pressure ventilation probably has a role for a subset of patients who have multiple hospitalizations and persistent hypercapnia, in a stable outpatient state. There have been clinical trials that have demonstrated reduction in hospital readmission in that subset of patients. And then surgical interventions probably also have a role for a small subset of patients. So lung volume reduction surgery has been shown to be helpful in patients who have apical predominant emphysema, and also sort of a Goldilocks scenario where their FEV1 isn't horrible, so it's above 20, but it's below 50. Bulectomy has been shown to benefit patients who have large bullae and also have severe symptoms. And then lung transplantation is an option for a subset of patients. Obviously, they're going to have to go through specialists to get placed for transplant, but it is an option, especially in your younger patients. When I was reading this, lung transplantation survival rates are now up to almost 6 years on average, which I think is much better than when I was a resident. I think the average life expectancy was like 2 years a couple decades ago. So there's obviously been some progress over the past 20 years. And then remember, palliative care is an option for patients who have severe symptoms and are suffering. The BODE score is probably the best way to assess individual prognosis. It combines a bunch of different measures. So the B is body mass index, lower is worse in patients who have COPD. The O is how severe their obstruction is. The D is the amount of dyspnea, and you can measure that with the MMRC. And then the E is exertion. That's probably the hardest thing to get in your office, but the pulmonologists do this all the time. So you can pull in the 6-minute walk test from their pulmonary visits, because most of these patients that have severe COPD are going to be co-managed by your friendly pulmonologist. All right, this was a broad 30,000-foot overview. I had trouble narrowing down the take-home points to just 2 or 3. So I actually have like 10 of them, but I'll go through them quickly and then try to answer any questions that you have. So first, think about COPD in patients who have chronic cough, dyspnea, or change in sputum production, particularly if they have a longstanding smoking history. Or for your patients who are coming from developed countries, indoor pollutants are actually a big source of COPD as well. Use the frequency and severity of exacerbations along with those validated questionnaires to help stage your patient into the ABE category. Smoking cessation for patients who are still smoking is really the cornerstone and most important thing that they can do to reduce morbidity and mortality. So remember that question about asking them if they're prepared to make a quit attempt in the next month. pulmonary rehab is underutilized, I think, and we should think more about referring patients for this. If they have resting hypoxemia, oxygen can improve survival, so don't forget to prescribe that. One of the big points is that most symptomatic patients should start with LAMA-LABA therapy. So remember that inhaled corticosteroids have a role as second or third line therapy, not first line. If the patient isn't responding to treatment, remember to assess appropriate inhaler use before prescribing another medication. And then consider advanced therapies or palliative care if they're not responding to maximal treatment. There are excellent resources. Again, I encourage you to download that app. The GOLD guidelines have summaries that I think are also excellent to reinforce anything that I said during this talk. There are videos online, there are care notes on Epic, there are tobacco cessation counselors. So there are things to help us, so it's not just on us to help our patients. And with that, I am happy to try to take any questions that you guys have. Yes?
How many people do you think in our system with a diagnosis of COPD actually have
I'd be guessing. I'd be completely guessing. I think more than have asthma would be, but that would be a completely random guess. I don't know. John?
Do you get low pulmonary function tests or do you would be
Yeah, so in order to diagnose COPD, you do need the post-bronchodilator for diagnosis, at least. Now, when the GOLD guidelines recommend annual spirometry for reassessment. I don't know how useful that is for management, so I didn't include that in the talk. But in order to do that initial diagnosis, you have to prove that they don't reverse back to normal after bronchodilator therapy. So if they have reversibility, then you might be looking at asthma as opposed to COPD. When I say reversibility, not partial reversibility, so their FEV1 to FVC, doesn't go from 50 to 60%. It goes from 50 to 90%. So that would not be consistent with COPD.
But you need full PFT bronchodilator or spirometry?
Spirometry with bronchodilator, I should say. Although I don't know if you guys have ordered spirometry without full PFTs. I always order just full PFTs on Epic. I don't know if that's have you ordered that, Brandon?
Yeah, I think the difference of PFTs get lung volumes.
Yeah, that's what I've always ordered. I mean, honestly, if you're not sure about the diagnosis, it does help to have, it could be restrictive disease. The DLCO can help distinguish between asthma and COPD. So I think those full PFTs, at least for diagnosis, are helpful. If you're doing annual surveillance, like the GOLD guidelines recommend, you don't need to, you can actually keep the patient on their therapy and just have them come back for standard PFTs without bronchodilators. Yeah, Lisa.
When you're initially expecting somebody to take a long time to come in with a cough and just sort of a steroid or something, how long does somebody need to be off a steroid or a bronchodilator?
Yeah, that's a great question. How long do they need to be off their bronchodilator? If you've empirically started something, actually look that up for this talk, because that's always something that I was wondering about. It depends on what preparation they're on. I think the pulmonary function lab should tell them that. So it's anywhere from like 6 to 12 hours for short-acting beta agonists to 36 hours for some of the longer-acting preparations. But they don't need to be off it for like weeks. Yeah, they do talk about it. And it's the same as what I've seen in everything. It's basically, we don't know, we don't recommend this. There are better, better options. And it'll probably take years to know whether or not that's harmful. They also talk about the fact that some of the additives in the e-cigarettes have been associated with lung disease. I think a lot of those have been removed, but I know that was a big thing a half dozen years ago. in terms of avoiding cigarettes. Yeah, so yeah, I think the question is, does that avoid health outcomes that we're concerned about, and no one really knows. Also, if that compared, nicotine replacement therapy, the thing that I've found helps the most, and I think the thing that has the best data is the varenicillin. If anyone else knows how to pronounce that, let me know before I go to Estes Park, because I feel like I butcher it every time I say it. Yeah, so is there evidence for screening for patients who have secondhand smoke exposure? So indoor pollutants, which I think would include secondhand smoke exposure, are a risk factor for COPD, especially like indoor cooking in developed countries. I would say that there's not really a role for screening, just like there's not a role for screening for patients who are smokers, at least at the present time. But if they have symptoms and they have a secondhand, I think there's a role for case finding if patients have symptoms and have secondhand smoke exposure.
Do you have a recommended model combo? I feel like I was we need that. Do you have like one or two?
I don't, because I think we're often limited by what's on the insurance formulary. So I don't really have a firm grip on, I always prescribe this and it's always covered by insurance. I think unfortunately, the insurance dictates typically what we can get, and there's no data really that one is superior to the other. Just like there's no data that one delivery system is superior to another. So I would use whatever is the least, potentially least expensive for the patient. Yes, John. Yeah, so in order to formally diagnose COPD, according to the guidelines, you do need the PFTs. I think if you have a patient that has symptoms and they have severe emphysema on their CT scan, you should certainly empirically start them. But I think getting those PFTs can still be helpful. I mean, it can help with potential prognosis down the road. It can help determine the severity of their COPD. So you can think about, third line therapies if they're not responding to initial treatment. It's fairly inexpensive. So I'd still recommend the PFTs, but I think there's certainly a role for empiric treatment. Yeah.
I've had patients who I was convinced were on the right meds, using them the right way, and they're still getting hospitalized. The question was like, is there some better delivery method, for example? So there's dry powder inhalers, and there's the mist, the MDI. And I've heard anecdotally, maybe I read it somewhere, I don't remember, that you need a certain level of lung function to basically inhale the dust that is in the DPI. And so I've switched those people to MDI. Is that ludicrous? Is that the right thing to do? Thank you.
So no, actually the GOLD guidelines recommend trying that. So I think that's worth trying. Yeah, the dry powdered inhalers, you need to be able to take a deep enough breath in order to activate the disc and get the medication into your lungs. So I think that would certainly be, if you needed prior authorization and you've had a patient who's been on a dry powdered inhaler, certainly I think that would get you prior authorization for a different form of the medication. And guidelines do recommend doing that. I would also think about whether or not they're on other therapies that might be helpful. But yeah, if they're maximized on their other therapies and you think, they're elderly and can't take a real deep breath, then it's definitely worth trying something else. All right. Yeah, thank you, everyone.